speakers here. This one is participant. This is outside view, not the speaker's view, I think. This would be the speaker's view.
We need to choose I'm not a robot. I need to choose joining from your. Okay, so I will disconnect this hotspot because I don't think it's very fast. And you're gonna use your.
I think I'll use mine.
Yeah. Then so if anything happens, I can.
Yeah.
Directly.
Let me just close tab and just open again.
I think you need.
I don't know whether Jenny. No, the problem is let me just shut down Zoom first. No, the one Jenny sent. Correct. I don't know why.
We have several people just to mute everybody coming.
Yeah. Okay. That means I'm on the right screen. That means I just messaged Jenny. It's already 5:49 already. So
I will talk to Jenny.
Yeah, just see whether I'm in the right place or not. FaceTime.
Your PowerPoint is ready. 喂，你呢？Seva 医生上线了，你看看他是不是在没得啥子参会的那个和那个是一个界面噻。
That Dr. Lee
Okay.
I think I'm okay. The rally is also here. Okay, I think it should be okay.
Okay, I will go outside.
Okay.
I will watch the webinar.
Yes.
Anything happen, I will turn on it.
Okay.
Hello, Robbie. How are you?
Hi, ready?
Hi, Seva. Good.
You're muted.
Fine.
Nice to see you. Yes.
Can you hear me?
Yeah, I can hear you, Seva.
Okay, good. That's now I couldn't hear. Okay, I just want to change my system. I think we are okay. I will wear my earphone, I think. Sorry, I just finished an operation, so I'm in this this suit.
Oh, okay, no problem. Are you still going surgery in this pandemic?
Hi, nice to meet you.
Yes. Hi, Dr. Lee.
Hi, Robbie. Lee. How are you?
Prof. Lee is probably on the line. Yeah, I just did a HIFU case actually. Rushing to finish the case.
Yes.
Hi, Prof. Okay, so really, I will introduce Professor Lee.
Yes.
And then you will introduce me.
Yes.
And then I will give the lecture. Then you will introduce. Then I will introduce Professor Lian Zhang. Yeah. And you will introduce Professor Felix. Okay, we will do that. I don't know whether Jenny is going to share the screen for this. Jenny, are you going to share the screen or the slides, or you want me to share?
Hi, Dr. Sewa.
Hey, hi.
So we are going to play a video first.
Sure.
Introduce the operation procedure. Then after
Okay.
that, at 6 o'clock, we will start the meeting.
Okay.
Okay. Chusi,
Alright.
please play the video.
Where's my? Oh, there it is. Okay. The slides of the speakers, are you going to play?
Yes, we are going to play from our side.
Okay, so you play that. So I will only play my slide. Yeah. Okay. Good. I just managed to finish the case, the HIFU case just now, but luckily very fast. 45 minutes we finished the case.
I can hear.
Yeah, I can't hear the video, Jenny.
Okay. So 45 minutes is very quick. Yes.
Yes.
Congratulations.
Thanks.
That is a big success. Yes.
Yeah, it's a very big adenomyosis. So and then she wanted to get pregnant. So we did, and one of the Dr. Huang from China is with me, teaching me how to do. Not easy.
Yeah.
Laparoscopic surgery is easier.
Yeah, that's right. It's always needed.
New things very difficult. Yeah.
Yeah, especially I think the adenomyosis is much difficult than the myoma.
Myoma, yeah, you're right. Because it's all over the place. Don't know where to go. It's not so easy.
Yeah.
And then especially those patients who want to get pregnant, you cannot destroy the endometrium, so you got to be very far away. Not so easy.
Yes.
Quite difficult.
Yes. And the patient also have some reactions.
Yes.
Yeah, after during the surgery, so it's make the treatment a little bit difficult. Yes. You concern about the thermal damages and the concern about the patient's emotions and also the
HIFU knife applied with FUS-focused ultrasound tumor therapeutic system allows in vitro ultrasound to enter the body and focus on the lesion, killing only the tumor without destroying any healthy tissue. It doesn't cause a wound or the loss of blood, and patients usually make a quick recovery after treatment. So how, by a few clicks of the mouse, does a doctor finish the treatment? As an example, let's see how the treatment of uterine fibroids is accomplished in 5 simple steps. Step 1. Locate the fibroids. Unlike a laparoscope, which via hands-on operation reaches and views the fibroids, the HIFU knife uses B-scan ultrasonography to find the fibroids, including those a mere 1 or 2 centimeters in diameter. Now B-scan probe starts to move from the left side of the womb. Good, the left border of the fibroid is shown. Then we record its coordinate, +30. Then move the probe to detect the fibroid's right border and record its coordinate, -20. That's how we find a 5 centimeter fibroid and determine its position. Step 2. Make a treatment plan. A computer will help us plan out how to kill a 5 centimeter fibroid. This process is like cutting a potato in slices, except that it's done via a computer. Step 3. Contrast-enhanced ultrasound. Contrast agents are injected to determine blood perfusion, to estimate the level of difficulty in treatment, and to distinguish fibroids from normal tissue for comparison with the result of post-treatment contrast-enhanced ultrasound. Step 4. Treatment. Wait a minute before pulling the trigger. We need to make sure of 4 things. The proper condition of the patient, a safe acoustic pathway for ultrasound free of intestines, a safe water level and temperature. Focus the point of the HIFU knife aimed right at the top. Plan we made in step 2. Now that the fibroid has been killed, all the patient needs is a few painkillers as well as some music and movies. And there's no need to worry about B-scan ultrasonography images because our product is equipped with both 3D magnetic resonance imaging and B-scan ultrasonography to achieve precise positioning and treatment. Step 5. Second time contrast enhanced ultrasound. Apply the contrast agents once again and we will find that the place where the fibroid once existed is no longer highlighted, which means the fibroid has been totally eradicated. That's the end of a successful operation. Isn't it easy and lovely without all the tiring procedures? Even though curing diseases is our duty, we do deserve a pat on the back from time to time. After the operation, nurse the uterus for 2 hours by cooling it down. Then the patient can begin having water, food and moving around. She will be able to return to work in 3 days. The residual fibroid will be cleared by the immune system. The patient will be able to get pregnant 3 months after the operation. The HIFU knife means hope for patients and is an important option for doctors. To learn more about the HIFU knife training program, please follow us on our official WeChat account.
Jenny,
Yes.
do you want me to introduce Dr. Raleigh?
Yes.
So I will say welcome, and then I will introduce my co-chairman, Dr. Raleigh, because Dr. Raleigh will be introducing me later. I just say that I'm Dr. Selva from Malaysia, and I will then introduce Dr. Raleigh, yeah? And then only I will introduce Professor Lee Chi Long. Is that right?
Okay.
Okay, right. Thanks. Okay. Dr. Raleigh, you pronounce this as Soitomo, isn't it?
Yeah, Sutomo, yeah.
Soitomo and Airlangga University, yeah? Okay, Soitomo, anything else I need to see here? Okay, I think the rest I'm okay. Okay, Chairman of Indonesian Permanent Contraception Endoscopic Task Force, Chairman of 19th APAGE Congress in Surabaya. Okay, excellent.
Dr. Selva, we can start now.
Hello, my name is Dr. Selva. I'm a consultant obstetrician gynecologist from Makuta Medical Center, Malacca, Malaysia. Firstly, let me welcome you all to this 2021 APAGE and International Society of Minimally Invasive and Virtual Surgery HIFU series or webinar. I would like to introduce my co-chairman, who is Dr. Raleigh. Dr. Raleigh is from the Department of OBGYN of the Sutomo General Hospital and Medical School of Airlangga University, Surabaya, Indonesia. He is a member of the Indonesian Gynecological Endoscopic Society, Asia Pacific Association of Gynecological Endoscopy, which is APAGE, and also the Asia Pacific Initiative on Reproduction. He is currently the chairman of the Fertility and Endocrinology and Reproductive Division of the Department of Obstetrics and Gynecology of the Dr. Sutomo General Hospital, Medical School of Airlangga University, Surabaya, Indonesia. He is also the chairman of Indonesian Permanent Contraceptive Organizations, PKMI Surabaya branch. He's also the endoscopic task force of the Indonesian Obstetrician and Gynecological Association and the general chairman of the 19th APAGE Congress in Surabaya. This was a very beautifully organized congress which I attended. Next slide. Next, I would like to introduce our chairman of the Board of Trustees of Asia Pacific Association of Gynae Endoscopy is Professor, none other than Professor Lee Chi Long. Next slide, please. So opening remarks will be Professor Lee Chi Long, and I think all of us know who Professor Lee Chi Long is.
Yes.
He is as I said, the past president of APAGE. Is also the Board of Trustees chairman. And let me invite Professor Lee Chi Long to say a few words.
Yes, thank you, Dr. Silver and Dr. Raleigh. Good evening, ladies and gentlemen. I'm Chi Long Lee, the Board Trustee and Chairman of Board Trustee of APAGE. It's my great pleasure to welcome you all to 2021 APAGE and Miss ISMIVS HIFU, the first episode of webinars. There are total 4 webinars holding from July to December. We will focus on HIFU, infertility, fibroid, and adenomyosis topic. And APAGE have held a series of non to minimally invasive therapy webinar in 2020s as well. With speakers sharing the prestigious knowledges, the webinar went very well. We deeply thank thousands of participants, even from Jordan, Vietnam, Japan, Oman, Turkey, Nepal, Indonesia, Europe, and the Latin American countries attending the event. And so it is always encouraging to receiving positive feedback from audience, which is our motivations to hold the webinars. The mission of HIFU webinar is to facilitate academic interactions in the new fields of the non-invasive surgery and promote endoscopic technique, knowledge, and education exchange between the hospital and the country among the Pacific areas. Choosing HIFU is the best not only in clinical study, but also service in this field. So that's the reason why APAGE would like to cooperate with Chongqing HIFU with so many conferences and seminars. The webinar will bring together prestigious pioneers to exchange skills and ideas. It is the outstanding opportunity to keep up today on the latest development in the gynecology you can have. I hope that the webinar will be fruitful, also reward of new knowledges and innovation. We expect more virtuous and physical conference and looking forward to seeing you. And I also wish that is a very successful event in tonight. Even they have a typhoon nearby the Asia region, but I think we can have a very fruitful the meeting. Thank you for your attention.
Thank you, Professor Lee Chi-Long. I must say that Professor Lee Chi-Long was actually my teacher in 1994 when I went and learned laparoscopic surgery under him in Chang'an Memorial Hospital.
Okay, let me, the next speaker is, thank you everyone for your join for the HIFU webinar. It's the first episode for the series, the webinar, even in the pandemic situation, especially in Indonesia. We still have got knowledge from the webinar, especially talk about the HIFU. And we have 3 speakers for this today. And we call for the first speaker, Dr. Selva. Dr. Selva is, let me introduce him. Dr. Selva is a consultant of OBGYN in Mahkota Hospital in Malacca. He's also received initial training in laparoscopy. As Dr. Selva said, he's got laparoscopies from Lee Chi-Long in Chang'an Hospital and from Song Wei-Young from Taipei also in 1994. And Dr. Selva is the vice president of APAGE and of the OBGYN Society of Malaysia, and currently chairs its endoscopy committee and is involved in promoting gynecology endoscopic surgery in Surabaya. Okay, Dr. Selva, please, time is yours. You have 20 minutes. And after Dr. Selva talk, we have 5 or 10 minutes for the question and answer for discussion. Please, Dr. Selva.
Okay, Jenny, can I share my screen? Okay, I'm going to share my screen now. Thank you, Dr. Relly, for your kind introduction. Today, my topic will be intramural fibroid and infertility, to operate or not. Now, we all know that uterine fibroid is the commonest monoclonal tumor in women. Fibroids may be the sole cause of infertility in about 2 to 3% of women. Current literature calls for the removal of submucous fibroids and possibly cavity distorting intramural fibroids to optimize pregnancy outcome. However, removal of non-cavity distorting fibroids, intramural fibroids, is still controversial. So when I say non-cavity distorting fibroids, are the fibroids like this that are present in the uterus, but it doesn't distort the endometrial cavity. Now, does this kind of fibroids cause infertility? And should we remove this fibroid? This will be my discussion today. Now, what is my lecture outline? What I'm going to do is I'm going to give the classification of fibroids. I'm going to talk about the pathophysiology of subfertility in patients with intramural non-cavity distorting fibroids. Then I will answer the question, does intramural fibroids cause infertility? The next question will be, does myomectomy improves the pregnancy rates? And lastly, I will look at all the other alternatives to myomectomy in patients with cavity distorting fibroids. Now, all this, what I'm talking about, is written in a paper, and the paper is also called the same Intramural Fibroid and Fertility to Operate or Not. And it's published a few years ago in one of the papers. You can, if you Google this, you can get the whole paper. So whatever I'm going to say is already written in this paper. So the first question is, what is a classification of fibroids? Now, traditionally, we know that fibroids are classified into submucous, subserous, intramural, and cervical fibroids. But the FIGO classification is more appropriate now. We have all these classifications. Number 1 and number 2 are submucous fibroids. Numbers 5, 6, and 7 are subserous fibroid. Number 2, although more than half will be inside the myometrium, it is also classified as submucous fibroids. Now, number 3 and number 4 are the fibroids which we call as intramural fibroids. Number 2 to 5, because the the myometrium thickness ranges from about 1.5 centimeters to about 3 centimeters. So if it's a big fibroid, it can go from the subserous to the submucous, and that's what we call as category 2 to 5. So what I'm interested is in number 3 and number 4. Does fibroids categorized as number 3 and number 4, which does not alter the endometrial cavity, are these fibroids causing infertility? And if it's causing infertility, what can we do about it? So that is my discussion today. So here you can see a patient that I recently saw. The patient has got a subserous fibroid and she's pregnant. So we know that these subserous fibroids are not a problem. And we know that submucous fibroids we have to remove, okay? So let's move on to the next slide. So I want to talk about pathophysiology. Now, when I talk about pathophysiology, I take most of what my discussion from this paper entitled Potential Causes of Subfertility in Patients with Intramural Fibroid. Now, this is the paper that I will be discussing. And in this paper, there are a few things that we need to discuss. First of all, implantation. Secondly, junctional zone. Third is uterine myometrial peristalsis. Fourth is fibroid pseudocapsule. And the last is steroid hormone. So all these factors will affect pregnancy in a patient with intramural fibroid. Now let's look at implantation. Now implantation is a complex process. We all know that. All of us who are doing IVF, we know that we can create a very beautiful embryo, but the embryo don't implant it. We don't know why. There are many factors that are involved. The factors are such as HOXA9, HOXA10, glycodelin, leukemia inhibitory factor, glutathione peroxidase 3, and HOXA10 is responsible for cellular differentiation, while glycodelin is responsible for promoting angiogenesis, suppressing natural killer cells, and inhibiting the binding of spermatozoa to the zona pellucida. So normally, these two factors are reduced during the follicular phase and increased during the implantation phase. And what happens is that when the patient has got an intramural fibroid, both HOXA10 and glycodelin are reduced during implantation. And because they are reduced, they may be the cause of a patient with intramural fibroid not getting pregnant. So let's look at the junctional zone. Now we know that the junctional is an area next to the endometrial cavity. It is seen very clearly in an MRI scan. And there are peristalsis in the junctional zone, and this peristalsis originates in the junctional zone. And disruption of the junctional zone by fibrosis may lead to increased peristalsis. So if there's anything that disrupts this junctional zones, for example, adenomyosis or fibroid, can increase uterine peristalsis. Thickening of the junctional zone, also caused by intramural fibroid, may lead to poor reproductive outcome. NK cells were reduced and macrophages were increased in endometrium closer to fibroids compared to other areas. So this may be another reason why a patient with intramural fibroids cannot get pregnant. Now let's look at this junctional zone. Again, we know that type 3 and type 4 fibroids. Type 3 fibroids are the ones that actually touches the endometrial cavity. Now type 4 fibroids do not touch the endometrial cavity. I have postulated that type 4 fibroids can be divided into two types, 4A and 4B. Now 4A are the ones that I think should touches the junctional zone, and 4B does not. So this is my own classification. I think that 4A, those fibroids that touches the junctional zone, will have a higher incidence of difficulty in getting pregnant than 4B. Okay, next let's look at myometrial peristalsis. Now there are two types of uterine contractions. One is called the focal and sporadic bulging of the myometrium, and the second is the rhythmic and subtle stripping movement in the subendometrial myometrium, and this is called the uterine peristalsis. Now, uterine peristalsis is captured by cine MRI, and here you can see cine MRI are MRI that are doing repeatedly to catch the movement of the endometrium, and this is a very laborious and expensive process. Now, what we know is that from menstruation to the mid-ovulatory phase of the menstrual cycle, the uterus contracts from the cervix to the fundus with increasing frequency. And because of this, the sperm can move from the cervix towards the fundus. Post-ovulation, contraction frequency decreases to relatively quiet, especially during implantation. So during implantation phase, the contraction is very minimal. And in the luteal phase, the direction of the peristalsis is reversed. That means it travels from the tube into the fundus and into the cervix, so that it will help the embryo to move from the fallopian tube into the endometrium.
Dr. Selva?
I think Dr. Silva is offline.
Yeah, I think it's a problem with the connection. Okay, we wait for a couple minutes. Sorry, everyone. Jenny.
Okay, so Dr. Silva now is changing to another computer. So we need to maybe wait for 2 minutes.
Oh, okay.
Okay.
Can you see me now?
Yeah.
Okay, I don't know, my computer, my internet, this has happened twice already. Okay, sorry, I will go back to the previous slides. As I said, this paper by Yoshino entitled Decreased Pregnancy Rate is Linked to Abnormal Uterine Peristalsis Caused by Intramural Fibroid. And in this nice paper, what Dr. Yoshino did is that he took 95 infertile patients with uterine fibroids, and then he did magnetic resonance imaging on them. Out of that, he found that 51 patients fulfilled the criteria, out of which 29 patients were found to have less uterine peristalsis, which is 0 or 1, and 22 patients have high frequency, which is 2 or more times per minute uterine peristalsis. So after that he found, and then he make them try to get pregnant without IVF, just by normal pregnancy. And in the patients who have a low uterine peristalsis, that is the 29 patients who have low uterine peristalsis, 10 out of the 29 patients got pregnant. That means 34% got pregnant, whereas none of the patients who have a high peristalsis got pregnant. So here he concluded that a high frequency of uterine peristalsis during the mid-luteal phase might be one of the causes of infertility associated with intramural fibroid. So I hope you understand. So basically he took patients and he did cine MRI, and in that cine MRI, 29 patients had a low peristalsis, and 22 patients had a high peristalsis. And out of the patients with high peristalsis, none of them got pregnant, whereas 10 patients, that is 34 patients, actually conceived. So he concluded as if there is uterine peristalsis in a patient with uterine fibroid, small uterine fibroid, they will have a difficulty in getting pregnant. Sorry, I'll move on to this. Okay, next is fibroid pseudocapsule. We all know what is fibroid pseudocapsule. A fibroid pseudocapsule is a capsule around an intramural fibroid. Now we know that these capsules contain smooth muscles and neurotransmitters, and they are very vascular, and they've got upregulation with endogolin and CD34. If the pseudocapsule thickness also varies according to the location of the fibroid. It is thicker in the submucous fibroid compared to intramural fibroid, compared to subserous fibroid. And cervical fibroid have got the thickest pseudocapsule. So the presence of pseudocapsule with cytokines, growth factors, and hormones may be responsible for abnormal uterine peristalsis, which may cause premature deliveries in women with intramural fibroids. So when a patient has got a very thick pseudocapsule, they have got a higher chance of increased uterine peristalsis, and also increased chance of premature deliveries, and also difficulty in getting pregnant. So the neurotransmitters in pseudocapsule is important in promoting inflammation and proper wound healing. And also it's important to do an intracapsular myomectomy without excising the pseudocapsule to reduce intraoperative blood loss, to enhance better uterine healing, and also correct musculature anatomical restoration to preserve uterine functionality for reproductive purpose. So the pseudocapsule is important when we do myomectomy, but it's also important in causing uterine peristalsis. So next we look at steroid hormones. Now we know that fibroid tissue contain a higher concentration of aromatase, estrogen, estrogen receptor alpha, beta, and also progesterone receptor compared to the surrounding healthy environment. Fibroid is also, we all know that estrogen dependent, but studies have shown, Ishikawa did a very nice study, and it shows that actually you need both estrogen and progesterone for fibroid growth. So what he did is that he took mice, and then he make them less responsive to progesterone and estrogen, and then he implanted them with fibroids, and only when you give both estrogen and progesterone did the fibroid grow. So high estrogen levels stimulates the junctional zone and induces rapid uterine contraction, and progesterone antagonizes its effect and suppresses uterine contractility. I think all IVF specialists will know that we give a lot of progesterone to patients to suppress uterine contraction, so that when we do an embryo transfer, the embryo will implant. But we know the high estrogens will cause uterine contraction. This is also one of the problems in implantation when we do IVF. So the next question to ask is, does intramural non-cavity distorting fibroid cause infertility? So here we can see all the papers that shows that intramural fibroid reduces fertility outcome. And here we have all the studies that show that it does not affect fertility. So when we have this kind of studies, when there are so many studies with contradicting effect, what we will look for review articles and meta-analysis. So this is the first meta-analysis that came out. It is by Sunkara et al. It's entitled "The Effect of Intramural Fibroids Without Uterine Cavity Involvement on the Outcome of IVF Treatment, a Systematic Review and Meta-Analysis." So here, patients who are undergoing IVF with intramural fibroids, but they are not cavity distorting fibroids, she analyzed, and this is what she came to a conclusion. She said that the presence of non-cavity distorting fibroids is associated with an adverse pregnancy outcome in women undergoing IVF treatment. So this is another paper. This is from China, and this is published more recently, which is 2018. And the title of this paper is The Impact of Non-Cavity Distorting Intramural Fibroids on the Efficacy of IVF and Embryo Transfer, and Updated Meta-Analysis. So in the conclusion from this study, this meta-analysis is that the present evidence suggests that non-cavity distorting intramural fibroids would significantly reduce the implantation rate, clinical pregnancy rate, and live birth rate, and significantly increase the miscarriage rate after IVF treatment, but it will not significantly increase ectopic pregnancy rate. So what it tells is that the presence of intramural fibroids, even if it is non-cavity distorting, will affect the pregnancy rate. So the next question to ask is, okay, now we know that a small intramural fibroids affects fertility. Does myomectomy improve the pregnancy rates? This is a very important question. Doesn't mean that you go and remove the fibroids, you will get better pregnancy rate. And here again, the literature is divided. There is a lot of papers that say that, yes, if you do myomectomy, you will improve pregnancy rates. Whereas there are also studies that say that it does not. It doesn't mean that you do myomectomy, it will not affect pregnancy rate. So how do you answer this question? So let's go back to this gentleman called Yoshino, who, remember I told you earlier, he did a study, he did cine MRI, and he found that all the patients with high peristalsis actually did not get pregnant. So what he did is, he took all these patients, 15 patients with increased peristalsis, and then he did a myomectomy on them. And he did the second MRI after that, and he found that 6 out of the 15 patients who have reduced peristalsis after the operation had achieved a pregnancy. So among 15 patients, the frequency of uterine peristalsis was normalized in 14 patients, and following myomectomy and the second MRI test, 6 out of the patients achieved pregnancy. So he concluded that the presence of uterine fibroids might induce abnormal uterine peristalsis, leading to fertility, and myomectomy may improve the fertility in these patients. So what does all this tell us so far? Now, in the discussion, what I've told you all is that intramural fibroids actually decreases pregnancy rates. And when an intramural fibroids increase uterine peristalsis, the pregnancy rates decreases. And we are unsure whether myomectomy in these patients improve pregnancy rates. So if there is increase in uterine peristalsis in patients with intramural fibroid, chances that myomectomy may improve pregnancy rates is better. Only problem is that we cannot measure uterine peristalsis because cine MRI is difficult and expensive. So we know that presence of fibroid decreases pregnancy rate, and we know that if the fibroid increases the peristalsis, then it will decrease pregnancy rate, and so we will do myomectomy. But unfortunately, we don't have a good method to measure the uterine peristalsis. So instead of doing that, can we do alternative method for removing the fibroid? Instead of doing a myomectomy, can we use other methods to shrink the fibroid? And these are the 5 methods that I have. You can use ulipristal acetate. You can use gonadotropin-releasing hormones or GnRH analog. You can use etosiban, you can use uterine artery embolization, or you can use HIFU, high intensity focused ultrasound. So I'll discuss each one of these one by one. Now let's look at ulipristal acetate. Now this is a selective progesterone receptor modulator. The advantage of myomectomy is that the patient can conceive immediately after treatment. There have been case reports where type 2 and type 3 fibroids, where they give ulipristal, and this type 2 and type 3 fibroids became smaller, and then the patient has conceived. And these are the papers that have come out, but we do not know whether it works on type 4 fibroids. But the only problem is that even in my country, it has been withdrawn from the market because of the worry of liver failure. So we don't have ulipristal. But if you have ulipristal acetate in your country, then you may want to consider using ulipristal acetate in patients with type 4 fibroids, shrink it, and then allow the patient to get pregnant. So this is one choice. The next choice is to use gonadotropin-releasing hormone, GnRH. Now, GnRH analog binds to GnRH receptor, causing desensitization and ultimately reducing the estrogen and progesterone, causing reduction in fibroid growth. GnRH analog also acts on the GnRH receptor expressed by the fibroid to reduce cellular proliferation. During the process, water diffuses out of the fibroid cells, causing shrinkage of the fibroid. Since there's lack of studies to determine the effect of GnRH analog on fertility, we postulate that significant reduction of fibroid volume by GnRH may reduce the impact of cavity encroaching fibroid and subsequently improve implantation. So there's been no study looking at GnRH for intramural fibroids, shrinking them and see whether they get pregnant. So this is an area where we can do research, and this is something you can try. This study by Castle, in 3 out of 5 patients with fibroid successfully conceived, 2 of them conceived without surgical intervention. So this is something that we can consider in patients with intramural fibroid. Next is etosiban. Now, etosiban is actually a combined oxytocin and vasopressin receptor antagonist. As an oxytocin receptor antagonist, etosiban competes with oxytocin at the oxytocin receptor in the endometrial cells to decrease endometrial contraction and prevent embryo expulsion during the implantation phase. By reducing the oxytocin effect, it inhibits oxytocin-induced prostaglandin production and increases the endometrial blood supply. As a vasopressin antagonist, etosiban relaxes the uterine arteries and decreases the systolic blood pressure to improve blood perfusion to the endometrium and myometrium. So the antagonistic effect of oxytocin and vasopressin receptor may improve uterine receptivity and embryo implantation. So now we know that uterine peristalsis is a very important factor in patients with intramural fibroid and fertility. So can we use etosiban to reduce the uterine peristalsis so that they get pregnant? Unfortunately, all the studies that have been done are for repeated implantation failures. There's been no studies to look at uterine peristalsis, but this is something that we can look at. We can use etosiban in patients with intramural fibroids and they are not getting pregnant, and we can give etosiban after embryo transfer to help patients to conceive. Next is uterine artery embolization. Now, uterine artery embolization is believed to affect embryonic implantation and difficulty in maintaining gestation, leading to increased miscarriages. The risk of amenorrhea and ovarian failure after UAE in young women is also low. However, there's a worry of poor oocyte quality and poor response to ovarian stimulation in patients who undergo uterine artery embolization. There has been several cases of intrauterine adhesions, endometrial atrophy, and fistula between the uterine cavity and embolized myoma post-UAE are described in the literature. In one study, more than 1/3 patients were found to have intracavity tissue necrosis 3 to 9 months post-UAE. So the American College of Obstetrics and Gynecology, the Society of Interventional Radiology, and the Royal College of Obstetrics and Gynecology have placed UAE as a relative contraindication for women desiring future fertility. So if a patient has got an intramural fibroid, we will probably won't advise uterine artery embolization, especially young women, because we are worried about the ovarian failure. So finally, let me look at high intensity focused ultrasound, or HIFU, which is our webinar today. Now, HIFU is an organ-sparing, non-invasive thermal ablative procedure. It uses extracorporeal transducers to focus a big intensity ultrasound beam to the targeted myoma to thermally ablate the tumors without introducing needles or probes into the tumor. MRI, there are 2 types of HIFU, this MRI HIFU and ultrasound-based HIFU. There is minimal damage to the surrounding normal myometrium without obvious damage to the elastic and collagen fibers in the normal uterine muscle, resulting in less scar tissue formation and less risk of collagen fiber hyperplasia. Theoretically, this would reduce the pregnancy risk in women who have undergone HIFU treatment for uterine fibroids as compared to myomectomy. Clinical studies have confirmed that HIFU avoids ovarian function impairment and adverse reaction, thus preserve ability to conceive. So studies have also shown that pregnancy rate post-HIFU is 95.4%, which is still higher than that post-myomectomy, which is 64% to 88%. So spontaneous abortion rate post-HIFU is 14.9%, is similar to post-myomectomy, 13 to 24%. This rate is still significantly lower than pregnancy with untreated fibroid, which is 20 to 46%. So high-intensity focused ultrasound appear to be a good modality which we can use to shrink these small fibroids. Instead of doing a big laparoscopic myomectomy or open myomectomy for a small fibroid, we could use HIFU to shrink the fibroids, and then the patient can get pregnant. So what are my conclusions? There are enough evidence to tell that non-cavity distorting intramural fibroids affect fertility. Type 3 may be a high risk for poor pregnancy outcome compared to type 4 fibroids. There are many possible causes why intramural fibroids affect fertility, but the only measurable cause appears to be uterine peristalsis. All others cannot be measured. Unfortunately, not all patients with intramural fibroids have increased uterine peristalsis. So currently, there's no good or inexpensive method of measuring uterine peristalsis. The only good method is expensive, which is cine MRI. We can use transvaginal ultrasound method. It is cheaper, but the modality is still very user dependent. So it's not very good method to detect uterine peristalsis. A better method needs to be devised to measure uterine peristalsis easily and effectively. So now we have vitrification, and a lot of us on IVF are now doing almost all frozen embryo transfers, and this frozen embryo transfer is improving. So I suggest that myomectomy should not be the first-line treatment for patients with small intramural fibroid. In patients with many frozen embryo, the strategy could be to consider surgical or non-surgical intervention only in patients who have failed embryo transfer. So if your patient have got a small intramural fibroid, you do an embryo transfer. But if it fails or keep failing, then you must consider whether you want to do myomectomy or you want to do HIFU. And myomectomy appears to be a big procedure to perform for small intramural fibroids. So of all the non-surgical methods that I described above, HIFU appears to be the most attractive option to shrink small intramural fibroids because it is non-invasive technique and has very few side effects. So these need to be explored in clinical studies. And this is what I'm going to do because I've just installed the JC200 machine. In fact, we just started doing a HIFU last week and we have done 8 cases so far. And my interest is here. I want to try and see whether we could shrink small fibroids and help a patient to conceive. Thank you. Back to you, Relly.
Okay. Thank you, Dr. Selva, for your very interesting talk about fibroid. And you know, we have so many problems fibroid with infertility. Okay, we open for the discussion, question and answer. We have 5 minutes to do discussion. Is everyone have any question? You can raise hand.
Okay, there is one question here, is from Dr. Indra from Indonesia. I think it's my friend, Dr. Indra from Semarang. How many intramural fibroid can you shrink with HIFU? Okay, I think Professor Zhang Lian will be discussing this in a little while. But I mean, from what little that I've been doing these last few weeks, we can actually do many fibroids, 4, 5, 6 fibroids. It all depends on location, the response of the fibroid. And sometimes we can do many. We can do many fibroids at one time. So all depends on the response of the fibroid. And I'm sure Professor Zhang Lian, who is an expert in this, will probably answer your question later, Dr. Indra. So there's another, another question by Dr. Indra is, can HIFU manage adhesions? No, HIFU cannot manage adhesions. From what I see, we can shrink fibroid and adenomyosis. As fertility specialists, I think adenomyosis is one of the bigger headaches. We can help to shrink fibroids, and we also can shrink adenomyosis, but it will not deal with intrauterine adhesions. In fact, if you ablate, if you use HIFU on the endometrium, it can cause adhesions in the endometrium. So we have to avoid the HIFU treatment of the endometrium. Now, how can we train in HIFU treatment? Very good question. You need to go to Chongqing to get the training. You can contact APAGE, or you can contact International Society of Minimally Invasive Therapy, and they can arrange for you to do the training. If you go and do training, it's no point, because only when you get the machine you should go training. So my thinking is you must try to purchase the machine or get a machine into a center and then go for the training. I went for the training last year, in January last year, and only only now I'm doing it, and I've forgotten everything I did the training for. So there's no point going for training until you are very sure that you are going to get a machine in your center. When do you do ET after HIFU? Now, I'm still exploring, but I'm sure you can do 2, 3, 4 months after the HIFU. When we are doing HIFU, we are trying to shrink the fibroid. The fibroid will take some time, 3 months, 4 months, 5 months to shrink. So once it has shrunk, then you can do the HIFU treatment. We know the oxytocin receptor is minimal in non-pregnant uterus. How does atosiban works then? Or what is your personal opinion, doctor? Now, good question. I have actually used a few atosiban for patients with implantation failure. Now, whether atosiban works on works to reduce uterine peristalsis is not been proven. We don't have any studies. Maybe somebody will need to do studies. But atosiban actually works on poor implantation failure. And atosiban, as you know, is a oxytocin and vasopressin receptor antagonist. So if there is no or there's minimal receptors in the uterus, in a non-pregnant uterus, there must be some patients which have got more receptors that is causing this uterine peristalsis, and that's why this works. And I can give you a little bit of experience. As I told you, I just started doing HIFU just last week, and we actually use oxytocin to compress the uterus when we do the HIFU treatment, and it works. I can actually see that when we use oxytocin in a non-pregnant uterus, it works. So I think there is receptors in the uterus, even in a non-pregnant patient. And so I'm thinking whether atosiban will work. So that's all the answer that I can give you.
Okay.
Dear Dr. Selva, yeah.
Still one question.
Last question. Yes, dear Dr. Selva, any data on fibroid recurrence rate after successful HIFU treatment? I think Dr. Zhang Lian will answer this question. We know that the success rate is in the region of 85 to 90% of ablated fibroid. There's still some fibroids that may recur, but the numbers are actually very small. If you have done a complete ablation, say 80% to 90% ablation, very high chance that recurrence will not occur. But of course, we cannot say that the fibroid may come back in a different place. That one we will not be able to know. Okay, I can't answer this question. I'll reply this answer in the chat box, and I will now pass it back to Dr. Rayleigh to introduce, or maybe I will introduce the next speaker, Dr. Zhang Lian.
Okay, please, Dr. Selva, you can introduce.
Okay, our next speaker is Professor Lian Zhang. He's the Secretary General of ISMIVS, International Society of Minimally Invasive Surgery and Virtual Surgery. And his topic will be pregnancy outcome of HIFU treatment for uterine fibroids and adenomyosis. I've known Professor Lian Zhang personally. I've met him many times. He actually came last year to, in fact, year before last, to give us a talk in the Obstetrics and Gynecology Society of Malaysia's Congress. Now, Professor Zhang Lian is a director of the Chongqing HIFU Hospital. It's a recent appointment. Congratulations, Dr. Professor. He's a chief editorial board member of the International Journal of Hyperthermia. He's a professor of the State Key Laboratory of Ultrasound Engineering in Medicine and a co-founder by the Ministry of Science and Technology and the Chongqing Medical University. He's also a professor at the Chongqing Medical University. He's received the first class in Science and Technology Progress Award of Chongqing in China in the year 2009. And second class in the National Science and Technology Progress Award of China in 2010. He has published numerous papers, 80 over papers in international and domestic journals, and more than 60 of them are SCI papers. And the highest impact factor is of a single paper is 16.95. And I quote many of his papers when I give talks, and it's a privilege to introduce and welcome Professor Zhang Lian to give his talk.
Thank you very much, Dr. Silva. It's my great honor to be here and have this chance to give this presentation. So first, I would like to, can you see my PPT?
Not yet, Prof.
Not yet.
Did you see it?
Yes.
Okay. So today I would like to talk about practice outcomes of patients with uterine fibroids or adenomyosis after high intensity focused ultrasound treatment. So as you know, high intensity focused ultrasound is a non-invasive treatment modality. Here is how this slide shows how it works. Like this is a transducer. The ultrasound beams were generated from this transducer and focused at a small point. During treatment, the ultrasound beams penetrate the human body and just focus at the tiny point of the tumor. So then during the treatment, we can see the grayscale changes. And like here, this is liver, here's the pancreatic cancer. And you can see the hypoechoic lesion. Then during treatment, we can see the grayscale changes like this. So when the temperature increased over 65 degrees, and we can see the changes like this, then tumor necrosis occurred. So here we can see how did we do this. Like this is we move the focus right here, and you can see the grayscale changes. Then we start solicate again. So we move the focus to this point. Now we can see the changes here. So when the grayscale changes area cover the whole tumor, then we can terminate the treatment. So after treatment, we can use MRI or contrast ultrasound to evaluate the treatment efficacy. So for example, this is a uterine fibroid, and you can see the perfusion before HIFU treatment. Then during treatment or after the treatment done, we use a contrast ultrasound to evaluate the treatment efficacy. We can see there was low perfusion. So MRI also shows the low perfusion in the fibroid. You can see from here, the tumor can be completely ablated and low perfusion. And you can see the surrounding structures, there was low damage. So it means no damage to the uterine, like the muscles. So after treatment, like this multiple uterine fibroids, we can see here, this before, and 1 day after that, even this small one, this tiny one, we can also ablate. And 4 months after that, MRI shows this treated fibroid disappeared, and only a small part of this one still there. And you can see the normal structures of the uterus. So also we can use this to selectively ablate the adenomyotic lesion and minimize the adenomyotic lesion and relieve the symptoms. And you can see selectively ablate the lesion. So after the treatment, also some case, you can see the uterus, for example, like this case, we can see the adenomyotic lesion located in the posterior wall of the uterus. And here, contrast enhanced ultra MRI. So after the treatment, this area, we ablated lesion over there. And 4 months after that, you can see the treated region almost disappeared, only a small part over here. And also you can see the posterior wall of the uterus return to normal thick, almost normal level. So this contrast enhanced MRI shows the thickness of the posterior wall of the uterus is similar to the anterior wall of the uterus. It means we can use this technique to precisely ablate the lesion and give the chance, offer the chance to the patients to get the uterus return to normal. So about the pregnancy after HIFU treatment, we already published some papers. And I don't know exactly how many patients, the numbers all over the world, probably thousands, something like that. But in my center, I just got the number yesterday, we already have 293 patients with uterine fibroids delivered babies after HIFU treatment. And also we have 31 patients with adenomyosis after HIFU treatment delivered the babies. So all the cases, we didn't have any complications during the pregnancy or during delivery. So here is these cases from my center. Actually, I didn't put the new number here. There's a 241 from my center. You can see these patients who want to conceive when they came to our center for HIFU treatment, and the average age was 33 years old. And here is the BMI, and also you can see we have the intramural fibroids and subserosal fibroids, and also submucosal fibroids. Here the different type of the fibroids, and also different locations. Like here, and the size, the median number of the size was almost around 6 centimeters in diameter. And the volume of the fibroids is 47 centimeters cubic. So this is a table shows the changes, the volume changes of the uterus and the uterine fibroids of these patients. And here, there's before HIFU treatment, the volume of the uterus, this is volume of the fibroids. And 1 month, you can see the numbers. And here, 6 months after that, we can see the shrinkage rate is around 17% of the uterus. And here is the shrinkage of the uterine fibroids is around 44% of the fibroid shrinkage rate. So this table is very important. And because at that time, we told the patients to try to don't get pregnant before 6 months after HIFU treatment. But you can see from these patients, it's 152 patients already delivered the babies. These all the numbers. And 1 month after HIFU, 8 of them get pregnant. For these patients, because they didn't listen to us, because before HIFU treatment, they said never get pregnant. So also we had 17 patients get pregnant at 1 and 3 months after HIFU. And here 27 cases get pregnant between 6 and 6 months after HIFU treatment. Around 100 patients get pregnant after six months after HIFU treatment. And you can say these patients with the solitary fibroids, and also some had the multiple fibroids, and also different type fibroids size, we compared. You can see we had some patients had the fibroids smaller than 4 centimeters in diameter, and also we had more patients had a fibroids larger than 4 centimeters. And here, I just want to show you how, like you may ask, why this patient can get saved within 6 months after that and didn't have problem. Here, I just want to show you a case. Like this patient had multiple uterine fibroids. You can see clearly this one was not so large, but she had many, and also some smaller ones. And you can see this before. If we perform myomectomy, probably we will suggest her to get pregnant 2 years after myomectomy. So for this case, she didn't get pregnant before. So after HIFU treatment, accidentally she got pregnant 1 month after HIFU. So this is the MRI. We got 1 day after HIFU treatment. You can see all these fibroids was completely ablated. There was low perfusion. You can compare with this image before, and also even a smaller one. So we ablated. The most important, we can see that from MRI, we can see there was low damage to the smooth muscles of the uterus. You can see the perfusion was normal. So that's why probably we don't need to worry about that. So that's why she get pregnant 1 month after that and deliver babies at terms. So also you may worry about if the HIFU treatment will damage the endometrium. From this image, you can see clearly, here is the endometrium. And this is normal smooth muscle of the uterus. And you can see here, there was low damage to the endometrium. So we can precisely place the fibroids without damage to the normal structures. So also, here is another case. I just, just somebody asked a question about how to avoid to damage the endometrium. For example, like this case, this patient had like the type 2 in uterine fibroids. You can see here is the endometrium, and this is the fibroids. The size was 5.8 centimeters in diameter. So you can see here also endometrium was very close to the endometrium. So for this case, we treated with HIFU, and 1 day after HIFU treatment, the MRI showed the fibroids was completely ablated. Here is the endometrium. So the margin between the endometrium and the uterine fibroids was 8 millimeters. So 0.8 centimeters. Here, there was low damage. So for this case, 3 months after that, she went to have the IVF and already successfully delivered a baby. So this about the uterine fibroids. Here, I just want to show you the results of the patients with adenomyosis treated with a HIFU. So this from Chongqing HIFU Hospital from April 2011 to June 2021. So 31 patients with adenomyosis already delivered babies after HIFU. Here is about the baseline characteristics of these patients. You can see here about the age and also the cause of the disease, like the average is like 7 years from the beginning to the treatment time. And also this is about the location. And 4 patients had the adenomyotic lesion at the anterior wall of the uterus, and 12 of them had the lesion located at the posterior wall of the uterus. The others had a diffusion. And here is about the volume. This patient and painful menstruation, 19 cases, and heavy menstruation, 3 of them had. So this is about the treatment time. So the treatment time is around 1 hour and 50 minutes. And here is about the solidification time. So this is the energy we used, the NPV ratio for the adenomyosis was large because it's different from the uterine fibroids. For this kind of for adenomyosis, we have to protect because there was low margin. Then we have to leave enough distance to avoid like the damage to the endometrium, also like the subsorum. No damage to this area. So the lung perfused volume ratio should be not large. I think for our case, like this 31 cases, the lung perfused volume just around like the 40% like this. So here is about the range. So the symptom improvement after HIFU treatment, here is before the pain score is around 7 points, and 3 months after that, significantly decreased. And also menstruation, like reduced by 50%, significant difference was observed. Here is about the conceived, like 27 cases conceived laterally, and 4 patients went to have IVF for the adenomyosis patient. And delivery, 24 cases had a C-section, and 3 cases delivered vaginal delivery. So also show you some cases like this case, and this patient, she was 26 years old, presented with dysmenorrhea for 10 years, and also with aggravated symptoms for 1 year. Dysmenorrhea starts 1 to 2 days before the period until 1 to 7 days after the period. So the most severe pain lasting 1 to 2 days, and she was unable to get out of the bed to work. So she married for 3 years with her pregnancy. And they tried different way to help this patient, but didn't work. So when they had the machine, like the JC200, then we treat this case, like here, with the lung perfused volume, just 51%. So after treatment, the patient get conceived 2 months after that, even though she had an induced abortion, but 4 months later, she conceived again and delivered the babies. And here is another case, this patient, and you can, from the history, we can see, and also from the MRI, you can see the lesion, adenomyotic lesion, located at the posterior wall of the uterus. And we just ablated part of this, like 51% of the volume. Luckily, she conceived and later and delivered a baby at terms, even though, of course, it's a C-section for this case. So, I mean, from our results, HIFU is really helps this patient for those, I mean, like they didn't get pregnant before, and it helps. So I think we can do a lot of research to confirm this kind of findings. And also another thing I want to emphasize about that. So we didn't have any complications for this patient during the pregnancy, also during the deliveries. Thank you very much.
Thank you, Professor Lian Zhang. Are there any questions? I think many of the questions Professor Aili Zhang has replied.
Yeah.
Let me see. Yeah, the one question is: do we need to deliver a patient by cesarean section after a HIFU?
And yes, that's a good question, because in China, actually the C-section rate was very high. So from our patients, it seems the C-section rate was high, but actually it was not really lead. So recently, the doctors from Spain, they published their results. So like 64% of the patients deliver laterally, like the vaginal delivery. So it's a really lead C-section, because like we said, we can precisely ablate the lesion and to protect the normal smooth muscle of the uterus.
Another very good question is, how about uterine rupture during pregnancy in post-HIFU adenomyosis patients? Any experience?
So So this is very important. That's why, so to avoid this kind of incidents, I mean, this kind of complication. So the most important is about the ablate, the range. So that's very important to avoid this kind of things. So that's why I said we don't need ablate. If the patient don't want to get pregnancy in the future, we can ablate large size of the adenomyotic lesion. But for those want to get pregnancy, 50% is enough. Then we can combine with other treatment. So to avoid this kind of thing. So in my center, we didn't have this kind of patients. I mean, get the uterine rupture during pregnancy. We don't have. And also in China, in other centers, I didn't hear about this either.
Another good question is, what is the best time to tell a patient to get pregnant post-HIFU for fibroids and adenomyosis?
So yeah, before we just always suggest them to wait for 6 months, because after 6 months, the uterine fibroids, the shrinkage rate is like 50%. So 6 months will be good for them. But so right now, we found like many patients get pregnant even 3 months after that, even 1 month after that, didn't have any problem. So, I mean, depends on the size and on the numbers of the fibroids. So generally, 3 months after HIFU should be okay.
Okay. I think the big advantage is you don't have an incision on the uterus, so you don't worry about uterine rupture and things like that in HIFU compared to myomectomy. Another question is HIFU increases preterm birth?
So far, yeah, that's also a good question. So based on my experience, our results, so after HIFU treatment will decrease the preterm birth. So probably like Dr. Silva already gave a very wonderful presentation, already showed us that's why. So that's why, based on my experience, same thing.
Yeah.
Or decrease the preterm birth.
If anything, it's going to decrease preterm births. Yeah. Is HIFU, will HIFU increase implantation failure or early miscarriage?
I think also, it's the same like the previous question. So also, we're decreasing miscarriage. I think I forgot to put one table to compare before and after HIFU, like the miscarriage rate, significant decreased in my center.
Okay, thank you, Professor Lian Zhang, for this wonderful lecture. It's always nice to listen to you and motivate me to do more HIFU.
Thank you very much. And you already did a very good job. Thank you very much.
Okay, I pass the baton to Professor Reddy. Professor Reddy, okay, you can introduce Professor Felix.
Okay, thank you, Dr. Silva. We forward to a next speaker, a last speaker for this webinar, Professor Felix Wong from Hong Kong. He will talk about how introduction of Hong Kong HIFU Center, and also he will give some surgery video for the HIFU. Okay, Prof. Felix Wong is conjoined professor of the University of New South Wales, chairman of ISMIVS and foundation chairman of China, Australia, Asia Pacific Forum of Minimal Invasive Surgery. Professor Felix Wong is renowned for his contribution to medical education in Asia Pacific countries. He made up to 10 overseas every year to Asia Pacific countries and offer teaching in the areas of gynecology oncology, endoscopy, women's health, and hospital administration. He also received awards from Endos Award in Medical Science and Technology China, Ho Chi Minh City Badge Award, the People Committee of Ho Chi Minh City, Medical Ambassador, Gynecology Endoscopy Group of Chinese Medical Association, Endoscopist World, China's Government Evaluation Committee of Endoscopy, and Guangdong Friendship Award, Administration for Foreign Export Affairs of Guangdong Province, China. Okay, Professor Felix Wang, it's time yours to talk about HIFU in Hong Kong. Prof. Felix?
Yeah, and coming. Sorry, trying to set up my slide and okay, everyone see the slide? Thank you, Chairman, for your introduction, and thank you for everyone to stay behind so late. And quick and Hong Kong HIFU Center. I'm going to share my experience in how to set up my center in Hong Kong. First of all, when, where, and how it started, all this happened. And it was an unusual opportunity and chances that in 2017, I met up with the founder of this HIFU machine in China during one of the conferences in China. I visited his Chongqing HIFU Medical Technology Company Limited, and I was impressed with the development he had with the HIFU treatment, as well as the way he provided teaching in the center, and as well as the treatment of his patient. I visited the center. I found that there's a well-established high technology company with great potential for a gynecologist. And this will be the present large factory and center. Now, in order to provide the HIFU ablation service in Hong Kong, I have planned the design of the HIFU center, learning the technology, establish the center, and promote the HIFU. And the centers I visited are many places in China. Also, I visited South Korea as well as Taiwan, and to see various other places, how they set up the HIFU center. You can see different HIFU center room on the side. Now, I find that the issue identified is doctor and patient communication in this one is too far away. And if teaching may affect the patient privacy in the other one. This one is too dark. You may not be able to see each other. And this is too crowded. And this one, the space is too large. And as well as this one, just like an operating theater. So I identified some of the problems that I'm going to set up my center, what it will like. And our friends, of course, together, we all try to learn this technology, including a few you may know, Professor Jiang Nen. And so I have no confidence until I visit Korea and a television interview. And I visit Korea, and I find that Korean had a lot of day surgery clinic with HIFU treatment. Because in Hong Kong, I probably want to set up a day surgery center, not in a hospital, but in a private sector. Now, that's how I begin. And the location will be in one of the old building, prestigious building for the medical. Inside is an old building built in 1958. Foundation stone, 1957. So it is in the center of Hong Kong Island. Now have to see the select the HIFU machine. And finally, I choose the JC200 because that will be suitable for my small room I'm going to use. And the JC is a bigger machine, even though they can do cancer surgery, other surgery, will be suitable for hospital. But for a private clinic, that's what I choose, JC. What are the problem, or what were the problem? How I set up the machine? I need to consider the building, the site of the building, the space, the weight bearing of the floor of an old building, the water pressure, the ceiling height, and the lift. You will see my problem is that it's a very busy district where my center is, crowded with people. I got only a room of 60 meters square. So I use half of it for the theater, the other half for other facility. For example, waiting room, consultation room, the learning room, change room, recovery room, preparation bed, and the theater. And why? Because Hong Kong, the rental is very expensive. Even this small room will cost me 15,000 US per month. Besides, there's no bigger room for me. This 62 years old building, we worry about the fall weight. So we need a steel plate to share the weight of this machine. The water pressure, you can see the water pressure is so high, we have some filter early on got broken because of the pressure. You can see we have to wash. And the machine, you see the floor is really just able to build the machine. So you can also, if your floor height is really too low, you can use the new machine JC200D. Now the lift, a small lift from an old building. We need to break the machine down into very small pieces and to carry it out and then rebuild it. Finally, we got everything ready and for the decoration. There's now the pictures or video on my center. You can see it's not like any traditional operating theater. It's very friendly. So all my patients love it. So I use this space for the theater. We need essential features, for example, medical consultation room for the patient, sign consent. I allow doctor to learn from here instead of crowded together in my theater. There need to be a change room, the recovery room, and also space for storage, oxygen, washing, cleaning, and medicine storage. All this need to be in your mind. Now, that is what the center look like, change room, reception room, and there's the consultation room, preparation corner, the learning observation room. I mean, doctor can stay here to see what we are going on. It's the one-way mirror so that you can see inside, the patient can see there are people there. And also this inside the theater. I learned one thing, is the light seems to affect the mood of the patient. So I use some LED light from New Zealand. They can offer different color, just like karaoke. So the patient won't feel that they are in a theater. Like in the traditional theater, you can see different color will make them more relaxed. Now you can see I turn on 2 color. The patient went into the surgery, they may thought they are in a karaoke. And for people who are watching from the observation room, they can see us operating as well as they can see all the actual pictures when we are doing it. We can have communication. The learner can learn and we have all the pictures. So, but we keep the patient privacy intact. Now, I also have a facility. You can see this is a 360-degree camera. So this camera allows us to be able to see the whole picture. But when I put a camera behind here, and you can see not only the operating, we can see that, but people, when they are bored, they can look around to see the nurse, to see what's operating. Because I learned from laparoscopic surgery, we all look at the television monitor. We are quite boring. So a 360-degree camera will help us or help other people when they are watching, can see elsewhere. Now, another features I have is to be able to monitor the patient temperature at the bottom. So when we are doing the ablation, we are recording the temperature all this time, instantly. So I find there is certain very interesting features. When you burn a fibroid and burn an adenomyosis, the temperature that radiate to the bottom are quite different. So in those days, my nurse is recording, and while the patient is having the treatment. Now, what I find that now I put it in front of me so that I can watch. And this is what patient who have ablation done for adenomyosis. I found that the heat spread in many directions. But for a fibroid, more on the right side, and you can see the temperature can rise higher and higher. I noticed that once it lasts for quite some time, the patient starting to complaining of leg pain or back pain. I need to move or stop. So very interesting infrared monitoring, just like when we are checking our temperature everywhere. So of course, my center have the various things other than the lighting, the wall, and we have monitor, we have security, we have the alarm and communication system. So this is the center where we have all this facility, just like facility with the traditional theater. Then we're starting to get doctor to China to learn from Chongqing. And when thing is ready, and we're starting to check the machine, get everything started. Now, my center, how to promote it? I talk to various people, and in lectures, our colleagues in ONG, and receive television interview, and visitor from overseas. We have distinguished VIP and expert from China visiting my center, as well as patient, their relative are joining them during the treatment. So I allow patient relative to join them, the mother, the husband, or even the friend. They sit next to them. So it's not only the patient admires of this treatment, the relative is going out and speak to all these other people. The most important are the patient. Once they receive the treatment, they agree for us sometime to tell them the expression, the impression, the experience, how the problem being solved. This is the number of patients we have treated. And when we first started, Hong Kong had some crisis. There's political crisis. However, despite the COVID-19, while the hospital are short of patients, our day surgery center, the number is increasing. However, lately, we might be too successful. The insurance company is starting to cause us some problem. You can see our number are dropping. But still, we maintain at around 20 1 month. For 1.5 years, we managed to treat 200 patients now. So that was in March 2001. We will soon have 300 patients in a month's time or two. So I thank all my doctors for the support. We're going to support this initiative and development. We went to Chongqing several times and visit other centers in China so as to learn this technology. I foresee the change of gynae surgery from what we have done, the advanced laparoscopic surgery, to robotic. To some extent, some surgery will be focused ultrasound surgery. My center have been written to tell people about this surgery theater design in a private clinic. Is published in the Journal of Gynecology and Minimally Invasive therapy. So when the COVID-19 is under control, anyone welcome to come to visit us in Hong Kong to see my center. You're welcome. You can also contact me with all this website and WhatsApp. I'm ready to answer some question about my center. Thanks for listening.
Okay. Thank you, Prof. Felix Wong, for your nice presentation. And we open for discussion, 5 until 10 minutes. From audience, is there any question? Okay, Prof. Felix, may I have a question for you? Are you still have any laparoscopy surgery after you're doing a HIFU?
Yes, quite a bit. Now, what happened is all the patients and come to you want to have the fibroid treatment. And of course, those suitable for HIFU, we do HIFU. Those unsuitable or they have other problem, and they always think, oh, but an ovarian tumor can also be treated with HIFU. So patients do come for all sorts of reasons. So our patient number did increase, many of my colleagues as well, so that we can offer them treatment, laparoscopic, open surgery, vaginal, all the surgery in addition to our HIFU surgery.
Okay. So not every fibroid or adenomasis will be solve problem with the HIFU, isn't it?
Yeah, because adenomyosis, in China, they can treat adenomyosis and find it very useful. We found that very useful as well. And however, because we rely on the insurance company to pay out. So the insurance company, one of the things they're saying that is experimental. They do not consider the China data. So because many Western countries don't have this surgery done for HIFU surgery for adenomyosis. So we have to explain and try to help the patient. It's getting difficult, but we'll try. Now I've seen a few questions is how many cases I'm going to do a day. Is that we do maximum 3 a day, usually 2. Now the reason is we have only a small space. We don't have time for the patient to rest. Usually after the treatment, they rest for 2 hours or 3 hours, and then they can go home. We don't have any hospital bed because we are not linked up with the hospital. So they go home after 2 hours. We have only 1 recovery bed. So that's the problem. But if the HIFU center is in the hospital, I think we can, like in China, if we got the patient, we can do around 5, because some of the fibroid, we can treat it with half an hour or 1 hour, 1.5 hours. It's not difficult at all.
Okay. Is there any from audience question? Raise hand. Maybe Dr. Colin Wu, any question?
I have one question here, very interesting. Is that do you have any medical issues such as medical radiation leak and any leak when you have HIFU in your private clinic? Now, HIFU stands for high intensity focused ultrasound. Ultrasound do not have radiation leak. Besides, in fact, we treat more patients who have medical issues that prevent them or put them high risk for laparoscopic surgery or open surgery. For example, deep vein thrombosis. For example, a patient who have cerebral hemorrhage just years ago, and any surgery will be difficult or will have risk, especially some with deep vein thrombosis who are on anticoagulant. In fact, we are treating patients with some medical problem which open surgery will not be able to do. Okay, now if there's no further question, one question is the number of staff and the qualification. My staff we went to Chongqing to learn from them, and then we just by practice and under Chongqing guidance by remote control and or their doctor can come to supervise us and to see how we are doing. So many of our doctors get benefit from Chongqing sending staff to us to help us to develop the center. The qualification will be in due course, APAGE, an individual country. We are going to try to set up the training for everyone. So hopefully we'll be able to help.
Okay, Doctor, from participant is Dr. Colin Mo. You have any question to Prof. Felix?
If not, I move to my other lecture now.
Okay, I think you can forward. Yeah.
Just to say hi.
Hi, first, very nice job. Do quite a good job here, and in a very short term, you get the 200 cases already. It's not so easy. And did you have any medical legal issue in the that is in the early stage, but it's quite easy to have some complications or something? Did you in the early 200 cases, did you have any problem in the communication with the patient or something?
Very good question. And early on, despite I select the patient, I make sure all the patients are able to have the HIFU without much complication problem. I myself did have a patient who have submucosal fibroid, not a big one, but 7 centimeter. After HIFU treatment, she had continuous bleeding and could be due to infection or what. But when she went to see another doctor, she was convinced to have a hysterectomy done right away. So that's the problem, that if the patient, when we first started, I'm not so convinced about the treatment, and whenever there's problem, they go to another doctors, and other doctor won't know what's going on. That could be one of the issue. Now, in fact, we are now treating patient, even the fibroid is up to 12, 14 centimeter. So in fact, it's not difficult at all. The larger the fibroid, maybe the easier. We need to know what type of fibroid it is. So in fact, we are lucky. Besides this, for medical legal problem, I know many of the medical legal people, especially the lawyer well. So they're helping us to set up our criteria. Okay.
Yeah.
Now,
Good
so
yeah.
if there's no question, I'll start because it's getting late, and I'm sorry that I rushed to the other lecture. Okay, there's the video presentation. Now, first of all, I must say, because due to the time zone difference, I can't have a live surgery. I hope we can, in the future, can apply surgery just like when we are doing a laparoscopic surgery. But before I begin, I may explain some of the operating system, because there are people who are very experienced and other people may just started to learn HIFU or may not have seen a HIFU system before. So I would like to just spend a little bit of time to present with some operating system and what we are looking at. And also, I must say I did speed up the video so that to save time. And for those who are very experienced in HIFU, please excuse me because I'm not as experienced as you are, but just give me good comment about this case, okay? Now, I'm starting to start off showing people the operating console, the interface we are using. And this is right side, you are controlling the transducer. This the right, the transducer will move to the right. This left, move to the left. This foot, the patient foot direction, H means the head direction. I hope people can see, but may be difficult by Zoom. A means the transducer go to the abdomen side. P means the back of the patient. And this is the PZ and PZ plus. Now, this is the ultrasound, diagnostic ultrasound in the center, where you control whether you can see clearly. Well, this is going to divide the fibroid or the uterus into many layers so that you can ablate or burn the layer, one layer by another layer. Now, the treatment is like that. You can see the patient lie on the machine. There's the uterus. And the transducer is going to send the focused ultrasound onto the lesion you are going to see. So you burn one by one, point by point, and then when you don't think enough at the anterior, you burn the anterior as well. Usually you burn more at the back because once you burn the one anterior, it may prevent more ultrasound to go to the back. So this is one of the principles we should use. We should burn the caudal side, the foot side, and then to the head, because in this way, the patient will have less pain because the sacrum is here and the lower spine is here. Sometimes the radiation heat can burn the, not burn, but causing pain on the patient. Now, so this actually how it operates. During the wheel time, you can see the ultrasound, we are moving the posterior, the transducer up. We can see the uterus over here. Now, we are going to find the fibroid, and there's in the middle. Now, usually the ultrasound is not, this ultrasound is not as good as what we are using in our clinic. We are using our ultrasound with very high resolution, but this one, after a while, you can see where's the fibroid. Now we are dividing the fiber into many layers. So each layer is around 5 millimeter. Depends on the size of the fibroid or adenomyosis, you can divide it into smaller layer. So usually we set at 5 millimeter each layer. We burn the middle layer where you have the largest area to burn and save. And then after you burn one layer, you move on to either the right or the left, and burn another layer and burn another layer until you finish. Now that's important. Later on when you see my video, you know what exactly I'm doing. What we are doing is not just one plane, but because it's three-dimensional. So by moving the transducer, you burn one layer after the other layer, either right or left. Now, however, the so-called focused ultrasound, they have a fixed focal length. Therefore, for some patient, some very obese patient, we need to make sure that the focal length can burn the lesion we want to burn, especially those posterior large fibroid. But some patients are very thin. The anterior fibroid, you might need to put a water bag so that you elevate the patient so that your focus point from the transducer will be able to focus at the fibroid. The way the nurse to learn how to use the water bag is very important because it saves you a lot of problem. Now, how do we know we have ablated the fibroid or the lesion adenomyosis we want to ablate? Now, it's the thermal necrosis of the tissue and will change the ultrasound reflection. So this is what we call grayscale change. And the more severe necrosis, you may have the white patches. I call it white patches. There's many names for it. And you can see that we have burned this. So later on in the video, when you see this, you know that I've already burned the fibroid. Now, how do we know other than these white patches? Sometimes it doesn't appear because we can only see some grayscale change. We use microbubble to be able to visualize how much, whether there's any still perfusion within the fibroid. Microbubble is very small bubble. Compared to normal bubble we have seen, it's 5,000 times less than the normal bubble. So it's phospholipid with gas inside. They travel along the capillary so that any fibroid with blood vessel capillary inside, it will be shown up by the microbubble. Just as this one, you can see this is a fibroid, big fibroid with endometrium here. And you can see the microbubble injected. And because the gas can serve as the ultrasound contrast, so that's why we can see the fibroid. Over here, we are turning from one side, the middle, to one side, and then go back to the other side, trying to assess how large the fibroid is. So you can see all this microbubble in the picture. Now, and then after we have done our surgery, the HIFU surgery, we then also inject microbubble. And at the end of the operation, you can see here, there's no more microbubble. Microbubble usually the sounding you can see, and the endometrium that's still intact. I can see the microbubble still there, but in the center you won't see any microbubble. So you turn from the center to one end and then back to the other end, trying to assess how big the area you have ablated. And of course, center may use MRI after the surgery the next day, but MRI in Hong Kong are expensive, so we are using this method. One of the most important issue is the focus point. We need to focus the area we burn, but make sure this acoustic pathway is without any bow. And it's important the bow have gas. The gas, any gas, have the ultrasound wave, and then they will heat up. And the more prolonged it is, they may burn the bow. So we make sure it is outside this triangle. So we are burning here, could be 90 degrees. Anything over here can still be 40, 50, we don't know. So we don't want the bow to be in between. So we always try to, some way, either distend the bladder, this is the Foley catheter, push the bow away, or put a water bag over here to push it away. You will later on see what I'm doing in the video. Now, so the patient I'm going to present today is a 47 years old lady with menorrhagia and severe anemia. She has a submucosal fibroid of around 4 to 5 centimeters. She requests HIFU ablation after learning the HIFU ablation. And the MRI show is a submucous fibroid, as shown in the video later. Now, the preoperative blood tests are done and localization tests. That means testing whether the fibroid can be visualized, the patient any problem. There's a test done before the actual operating procedures. We don't want to have a patient who cannot have this surgery occupying the theater time, so that we have done everyone localization tests to test is fairly feasible to burn, to ablate the fibroid. So the HIFU ablation was carried on the last day of last month, to record it for this section. Now you can see this is MRI showing the submucous and mucosal fibroid. And we usually see a field image, T2W, and this is a hypo intense fibroid over here. So after we assess the size, assess other things, whether there's any other fibroid, and we're starting to do the procedures. Now, that's how we prepare the HIFU ablation. There's, within the theater, you can see while we doctors are discussing about the case, how we go about it, and you'll notice that there's a large television here. I allow the patient some time to look at it and also explain to them what I'm doing, rather than we are doing it ourselves. You can see my setup here is my infrared monitoring is over here. Now, what the nurse is going to set up, we put a frame over her buttock so that we can put the infrared camera around here. So now you can see what the nurse are preparing. Now, so put a frame there, my infrared camera just over here. So we cover it so that the patient will not look like Nick. And because we need to let the buttock to elevate the heat if it's go through the buttock. Otherwise, the patient may complain of pain, or we cannot cover them with any coating. So when the patient is ready, we are ready, then we can start to do surgery. At first, I would like to do something like with a Zoom, hopefully with this type of platform, to be able to share my operation with other people. And however, I find that it's difficult. Now, this is the setup of the HIFU when we first started using a Zoom. Now, to start with, we increase the water level so that they can cover the patient lower abdomen, because in this way, it will cool down the temperature that may be there. Now, you see in the Zoom, when we take the video, it's not clear enough. So later on, I will show you more clear pictures from some of the recording I have from Chongqing. And however, you can still see what I am doing. I'm going to explain it. And we are moving because it's not going to be so clear. I'm using a faster speed. Now, we try to localize the fibroid, the uterus, and also to see the fibroid here. Now, I will explain to you what we are doing. And then in this way, we show the Doppler to outline the fibroid. Because the fibroid uses a pseudo capsule, you can see the Doppler surrounding it. So you know that it's the fibroid you are ablating, just like in here. So you can transfer the image by pressing this button. They will transfer to here. You can take a picture just like previously. I got a frame here. Now I'm doing a micro bubble. Now the micro bubble in this one, you can see there's micro bubble in the uterus. Sorry that you may not see clearly. Also, I speed it up. You can see the fibroid, and I'm recording it. And so after I see the micro bubble, I can identify the fibroid is here. This is the one, the focus point. I need to lower it to here. But when I lower it to the fibroid, I find that the gas going my way. So I need to put a balloon bed, water bed over here, so that to elevate the patient abdomen, so that I can have this focus point onto the fibroid. And then I need to divide the fibroid into various layers. That's how the so-called planning is doing. So this, I identify where is the fibroid, for example, from how many centimeter to how many centimeter. So I divided the fibroid into many layers. I started from the middle layer when I'm going to ablate. So I set the temperature, the voltage to 400 volt, and then set it to hit it 1 second, relax for 3 seconds, and in this way, 5 repeat. That means burn 5 times. You can see the number of seconds you have ablated the tissue. Now, in fact, by pressing this button, it will turn red. Now, whenever the water content is too low, and there's various alarms to help you, you can see already there's white patches appear. Now, in order to see clearly, I show you the video I got from, this is the video I got from Chongqing, a better recorded video. Now, again, I show you the later parts of the video. Now, so this is where the bladder is here, and the fibroid is over here. Now, so I'm changing, starting at the center of the fibroid after the microbubble, and I set the voltage to 400. You can see I press here, it turned red, so it is ablating. So it ablates 1 second and rest for 3 seconds. So that's the amount of total second I burn. So it's also recorded over here. And how many seconds are burned. And you can see after 10 seconds, there's already white patches appearing. And there's sometimes without patches, you can see the grayscale change. When you first started, I must say that it's difficult to visualize the changes. Only when there's white patches, you're starting to say, hey, we are doing it. But now you're able to see the fibroid. You can see I have moved from 4 to the other level, 5 level now. This a technique I learned from Dr. John. It seems that if I'm going to ablate the one whole area together, I need to move the machine, and that might have the bowl in between. So instead of moving to the front, I burn each of the layer at the posterior caudal bit first. Now I move from the 4th now to the layer 6. So when I see the ablation is more or less enough, I move to another layer. There's another layer, I'm moving. So when you move the other layer, there's not much white patches. And the more you ablate, the more you're able to see. Now, this is the one after ablation, but there's already too close to the edges of the fibroid. We are told we probably don't go to the edges of the fibroid because this one, remember, is submucosal fibroid. We don't want it to burn too much into the endometrium. So we are moving from 4 to another layer on the right side. This is the right side at the level 5. So all at the posterior. And so at the caudal end, we want the heat to spread to the south or to the abdomen direction and to the front. You can see weakly the fibroid. Now I move to another layer at the side. So after burning, you can see it's quite obvious, and the fibroid starting to have all these white patches or grayscale change. This is, if they are not white patches, sometimes you can see grayscale change, and you can see this the fibroid. Now, but I admit that this one, I am putting it a bit too low. I need to burn, the fibroid is larger than this, so I need to move on. So what I did is try to identify the location, the size of the fibroid by the Doppler. So that's what I have just done. But you can see more or less the fibroid I can see is other than the posterior, is not enough. So that is the whole fibroid. And I use Doppler to identify it as well to help me. And then the front, it still needs some ablation and the top a bit. So I try to relocate the waterbed in this way to push the bow away. So you can see the waterbed is more moved to the caudal end. So I moved the pointer, the focus, to more to the caudal end so that I burn deeper. In this way, I managed to ablate the whole fibroid. I would say could be 100%. But when you see, when we have already white patches in front, it's more difficult to see the changes at the back. But still, you are delivering some energy over there. So it still burns the fibroid. Later on, by micro bubble, you can see the appearance of the non-perfusion volume. So I'm already moving, trying to burn. It seems that it doesn't move. And so a middle first and move to the side. So, and this is again, further on, I just give a few heat at the middle of the fibroid. Because every time we put the waterbed, sometimes the uterus can be moved a little bit. So that's one of the problem. Sometimes we need to be able to see what we are ablating and how large is the fibroid. And now, when we think we are more or less finished, then what we are going to do is to inject microbubble inside again. So is going to wait until one thing is you can see the fibroid and being burned. There's over here. Now this is the microbubble. Now, one thing is we are using oxytocin. You can see there's no perfusion in the fibroid. So I'm turning it from one side to another. When I measure the size, it corresponds to the size of the size of the submucous fibroids in the MRI. So I usually compare here and the appearance, and so before and after. So, and I use again the Doppler to outline whether this is the real fibroid I'm treating. So that's how I finished this case of a 5 centimeter fibroid. So I managed to complete the procedures in 30 minutes for this submucous fibroid, and the patient recovered well 1 hour in the clinic. She was discharged home with analgesic, just some painkiller. She will remain well and come back to follow up in 1 week's time. And her fibroids already show shrinking in size from 4.5 times 4 centimeter in the MRI in this pictures to 3.1 to 3 centimeter by ultrasound. So she did not have any side effect or complaint. She will be visited again in 1 month and in 6 months' time. And we believe that this size of the fibroid, if it's effective, it probably disappear within a year. So hopefully her menorrhagia and all that will be will be under control after 1 or 2 bleeding. Now, that's the whole for the presentation. And I choose a case, not a difficult one. Unlike our laparoscopic surgery, we usually show the skill we have for difficult one. But because of the time limitation and otherwise it can be very boring. But there's quite a lot of technique we need to learn. So especially for multiple fibroids or adenomyosis. So this is just a simple case for me to present. Thank you for your attention.
Okay, thank you, Professor Felix. Maybe one question from audience? Okay, one question for you, Prof. Felix. Is there any contraindication for the HIFU?
Yes, in some big fibroids, especially MRI, the T2 weight image, if it's hyper intense, that means they're quite vascular. Then it's very difficult to ablate. It may take too long a time. And we usually make sure that oxytocin can control. Now, of course, the other major indication is that any suspicious of is leiomyosarcoma or any lesion with possible malignant change. We need to be very careful. Now, some position of the fibroid are not easy to ablate, and some may be easy for laparoscopic surgery. For example, a pedunculated fibroid. Okay, so otherwise it will be, yes, we can ablate it. It takes a long time to become regress. The lump is still there. So now, in fact, we can ablate nearly up to 90%. Patients will come to us. So the rest depends on the level of the skill. So I myself set up the fibroid into various levels of skill, just like our laparoscopic surgery, so that hopefully our doctor will learn the skill from one level to another. But unfortunately, it's not that easy. We use just one section. One question is, how many sections are used for large fibroid? The machine from Chongqing is very effective. If you do well, we just use one section. We don't have to use the other section, even for 12 or to 14 centimeter fibroid. And of course, why people asking this question, especially the insurance company, because there are some other hyperthermal machine. They are not as effective as the machine we are using from Chongqing. That's why they may need several sections to avoid the skin burn and other not effectiveness. Then they need to use several sections to do it. Now, one question I can see is the HIFU in degenerative fibroid or degenerating fibroid. Yes, we have many fibroid. They are large. They also have area of degeneration. But degeneration may have a problem when you hit at it, but we are using the MRI to guide us as well. And we can know where the degeneration, but it still can be done. And the degenerative area already is not going to grow. So it doesn't really affect your result too much, but it may take a long time for it to regress. Okay, so yes, we can do it. And so the courses, provide any course for HIFU. Yes, APAGE and many of our center, we are trying to set up some training program together with Chongqing HIFU and some center in China. It's going to hopefully provide training course for people who learn HIFU, how to do it. And in fact, the International Society of Minimally Invasive and Virtual Surgery Society do have quite a lot of teaching on the web. People can go to the web to see many of the teaching from this society website. So, okay, any other question I may see? Yeah, I think more or less the question I've answered. Any other question?
I think it's
one question is what kind of complication or HIFU procedures often occur for beginner? Now, for beginner, you know the limitation, just like laparoscopic surgery. I think HIFU surgery should be trained, not just by observing more, but to do it under supervision, under good supervision. So in this way, we'll minimize the complication. Besides this, I mean, there are fibroid that can be, or adenomyosis that are difficult to do. And for example, posterior fibroid, large fibroid, anything more than 8 centimeter, multiple fibroid. And so we should have various level of skill to learn and various level of fibroid. But unfortunately, we may not be able to divide so closely different type of fibroid. Okay, and I think that's all. I'm getting too late now, I believe.
Yeah. Thank you, Professor Felix Wong, for your nice presentation and discussion. And I think we has already the end of the webinar today. Is very interesting talk about HIFU, and also and then give time to Dr. Selva to close the webinar. Please, Dr. Selva.
Thank you, Dr. Relly. So thank you for attending this webinar. Our next webinar on APAGE and the International Society of Minimally Invasive and Virtual Surgery HIFU webinar will be held on the 26th of August 2021. And you can see the program there. There will be talk by Professor Chi Rui Zeng from Taiwan on challenges of myoma, uterine, and adenomyosis in fertility management. And Professor Felix Wong will be speaking on why HIFU is the option for treating uterine myoma. So please join us to attend this webinar again in August 28. The more you listen to it, the more you will understand how HIFU will be one of the armamentarium of methods that we can use to deal with uterine fibroids and adenomyosis. And what has been said is that we cannot use HIFU for all our patients, for all the treatment, but in some patients, it is a very useful modality of treatment. So with that, I conclude this webinar. Anything else for me to say, Jenny? Is there any other slides?
No more. Thank you, Dr. Silva.
Okay, thank you very much, and see you again in August. Bye for now.
Bye. Thank you, everybody. Thank you, Prof. Lee.